This patient suffers from serious hypertension and diabetes, which are the main risk factors of his disease. His echocardiogram showed an ejection fraction is 59%, with significantly reduced movement of the interior and posterior walls. That there was an acute occlusion in left circumflex artery with TIMI flows grade 0. Next. There was a serious stenosis in the proximal LD with severe calcification. There was an obvious coronary artery fistula in the first diagnosis. There was a serious stenosis in the proximal LD with severe calcification. There was an obvious coronary artery fistula in the first diagonal branch. And the final result tended to be satisfactory. The QFR of LAD was 0.65. The QFR of RCA was 0.62. Virtual stent technique simulates the effect of the stent implantation in select segments using predicted value of QFR. By using a QFR-based virtual stenting technique, the QFR of RCA may be increased from 0.62 to 0.96. The QFR of LAD may be increased from 0.65 to 0.95. We have performed a CTA on the patient, and the results showed that there was a serious stenosis with severe calcification in the left main to the proximal LAD, and a diffuse stenosis within the lipid calcified plaque in the proximal to middle segment of RCA. The stent in LCX had good expansion.
Now we can see the aorta, the right coronary artery, and the left coronary artery. And now let's hide the aorta. We see there's some calcification in the proximal and ostium of right coronary artery. Now we hide it and we see the image and rotate it. We can see there's heavy calcified plaques in the ostium and proximal LCX, and also in the proximal to mid LAD. Hide the LCX and its calcified plaques and the excellent stent in the LCX. Now we rotate the LAD image freely, and we can see that there's almost a 270-degree calcified plaques around the LAD. Is the rota or IVL may be a good choice for the case.
It's a multivessel disease. There's severe stenosis in RCA and intermediate to severe stenosis in proximal LAD with lots of calcification. And there's also a clear fistula connecting the diagonal and to the left ventricle. So we did the virtual stenting. It gave us some guidance how to put the stents. So Dr. Gong, do you agree with the virtual stenting strategy? What's your thought on this patient?
We can say that if implanted two stent in the RCA middle segment, the QFR could significantly increase to the about 0.92. And in fact, for this patient, firstly, we complete the RCA PCI with intravascular imaging guiding. We complete RCA leading PCI and implanted two stents.
Dr. Gong, from the angio, I think we can see there's some calcification in the proximal RCA. Yeah, so from the AVUS, I think the middle and the distal parts are say okay. It doesn't have a lot of calcification, but it does have some calcification in the proximal RCA. And you pre-treated the lesion with NC balloon and cutting balloon. I think the result was very good because you get the stent well expanded, and then you run the AVUS again after the stenting. Can you show us the AVUS after PCI in the RCA?
Yes. Let's see the run 7, the last run. Can you give me the last run? Okay. You can see the stenting is good. Expansion and a good position. But in some segment, there are a little plaque or tissue prolapse. But according to the contemporary criteria, will not be treated further.
Because there's a fistula connecting the first diagonal into the left ventricle. So what's your strategy?
Next step, we are focused on LED lesion, and according to the baseline QFR result, we can see the QFR is about 0.62. In this patient, we used microcatheter-based FFR technique to re-evaluate the hemodynamic significance of LED lesion, and our FFR result showed 0.65. It's very agreement, and so the LED lesion should be treated with PCI because of the significant effect on the hemodynamic. And next, we will perform intravascular imaging.
Yeah, you know what, Dr. Gong, I think after the pressure microcatheter FFR, we confirm the result of QFR, and this lesion in LED should be treated. Actually, the pressure macro FFR is a new technique invented by a Chinese company. Yeah, you're right. I think whether or not the fistula have impact on the functional assessment, it depends on the location of the fistula and also where it drains to, right? So right now, I think Dr. Gong has run the AVUS in LED, right?
I was check from the longitudinal view, and we can see at the distal of the LED, there is a relative large muscle bridge, and accompanied with the pullback of the IVUS, maybe there is a relative optimum landing zone of the landing, the distal stent. And during the pullback, we can see there is some superficial calcified lesion.
Okay, from the AVUS, I think in the distal parts of LED, there's myocardial bridge, and after that, there's some calcification, but not that severe. And then when we put back further at the proximal part of RD, I think the calcification is very severe. So Dr. Gong, for this kind of lesion, what's your pre-treatment strategy?
We should pre-treatment follow to get stent optimal result. And for the calcification lesion, firstly, we will choose intravascular lithotripsy as the first strategy to pre-treat the calcification segment. And after pre-treatment, we will perform intravascular imaging. Then we will implant the stent, and after stent, we will perform function assessment to guide our further optimization technique.
So from the angio, the left mean is very short. So now you want to check the morphology of the left mean. One more AVUS run from circumflex to left mean, right?
Yes.
Okay, let's mirror the MRA of the circumflex is 4.12 square millimeter. And we can see from the 11 to maybe 2 o'clock there, and the 5 to 6 o'clock there have two superficial calcification, uh, calcified nodule, which lesion is already protrusion into the lumen vessel.
Yeah, because the lesion is very diffused in the RD from the middle parts to the ostium. So I think probably you may put two stents and you have to run one more AVUS in the first diagonal to see if there's there's a severe stenosis at the ostium of the first diagonal. Dr. Zhang, actually Dr. Gong did the pressure microcatheter FFR to confirm the results of the QFR. Because I mentioned earlier, this is a very new technique. It was invented by a Chinese doctor. So what's the advantage of this new technique compared with the pressure wear?
I think the most advantages of this device is it can deliver from the workhouse wire to the distal of the lesion.
Mm-hmm.
As we know, the classic wire-based FFR has the relative poor maneuverability of the pressure wire. But if we use the workhouse wire to the distal and deliver the catheter based on the previous wire, I think it's quite safer and easier.
And the good thing is, if we perform the pressure microcatheter, after stenting, we can just keep the wear inside of the lumen. We don't have to rewear after stenting. This is also one of the advantages with the microcatheter. Yeah. But the only problem with the microcatheter is profile is a little bit bigger than the pressure wear. So that could be a problem. If it's a very tight lesion, it may overestimate the stenosis severity.
Yes.
So right now, Dr. Gong is doing the AVUS in the first diagonal, right?
Yeah. If after stenting, the often of the first diagonal branch is occluded by the structure of stenting dent, and we will perform piston balloon inflation. Next, we will perform pre-dilation of the LED lesion.
Mm-hmm. With AVL, right? So with the AVUS image, and then you can choose the AVL based on the length and the arc of calcification, and also the lumen diameter, like what kind of AVL you may choose.
Stenting strategy is to fully cover the lesion is 54.11 millimeter.
So based on the AVUS image, Dr. Gong, what size of AVL balloon you may choose?
We will perform about
3.0
to crack the calcification.
And also, before the AVL, we have to make sure where is the good spot to do the AVL, and then we can get a better results. So still, the AVL is just one of the options for the treatments of calcification. Sometimes we have to use rotational atherectomy, some NC balloons, or cutting balloons, scoring balloons. It really depends on the lesion. It's very tight. We cannot deliver the AVL balloon. We have to do the rotational atherectomy to make enough room, and then we can deliver the AVL. And sometimes we have to use, both RA, AVL, and also some balloon dedicated modification techniques. It's a combination.
As we see in the imaging result from circumflex, and the often calcification of circumflex is also moderate to severe. We'll try the AVL pre-treatment.
So you want to treat the ostium circumflex with the AVL first?
LED then I will pre-treatment first.
Okay. because of the calcification at the ostium of circumflex. So you are kind of worried that after you put a stent from the proximal RD to left mean, and there's a risk of the circumflex occurring, right?
Yeah.
Yeah.
Okay, we will perform the IVL procedure.
Mm-hmm.
First, we will inflate it to 4 atm,
Mm-hmm.
and then ready. Are you ready?
So now we can shock.
Press the button.
Press that ready. Yes. Okay.
Now it's shocking.
Yes. Okay. 6 atm.
Mm-hmm.
6 atm, and then deflate it.
Mm-hmm. So after the shock, we increase the pressure to 6 atm to see if the balloon is can be well expanded. If it can, that means the AVL works, right? You know, there's an interesting thing with the use of AVL. When we give the shock wave, because from the ECG monitoring, we could see some PVC, premature ventricular contraction. Do you think that's a problem we should be worried about, or it's all right? It's just a phenomenon we may observe when we use AVL.
No, I think it's relatively simple.
Mm-hmm. It's quite common, right? When we give the shock, because we
Yes.
could see the premature bits on the ECG monitoring.
Yes.
So right now we give like 4 times of the shock wave.
Yes.
Do we check the imaging test, or you want to give more shock wave?
Yes.
Or one more time?
Yeah.
You know, to me, the shockwave is kind of new. Before I thought, you know, when we use the shockwave, we should hear some sound like pa 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 pa. But actually, there's no sound, right? It's kind of silent.
Okay.
And some doctors do prefer to use AVAS, and some doctors do prefer to use OCT. So it really depends on the personal preference. So I think Dr. Gung prefers to use AVAS.
Yes. Because the stent will be implanted into left main,
Mm-hmm.
and for this casing, I think IVUS is optimal choice.
You're right, because the left mean the diameter is much bigger, so AVAS is a better imaging modality than
Yes.
OCT. Yeah.